Hi, everybody. Dr. Michael Miyazaki here again. Thanks for joining me. Today, we're going to talk about endodontic irrigation, which is such an important part of doing a root canal. And I want to point out some points of interest, what the irrigants do, why they're so important, and what irrigants to use. And so we're going to build on this during upcoming programs. So I just want to go back to last week. Last week, I had a patient that came in on Friday, called her office Thursday afternoon. Turns out to be a 32-year-old male, and he had been experiencing pain on the lower right side since the previous Sunday. Wasn't able to sleep, wasn't able to eat. Calls her office Thursday afternoon. So we appoint him at the very first appointment we had, which was Friday morning. Luckily, our 7 a.m. appointment had opened up, and so we were able to squeeze him into that time slot. Comes in on Friday morning, 7 a.m., look at the tooth once we get the PA done, and it's just bombed out. The whole mesial half of that tooth is just radiographically soft. We know that once we scoop that decay out, we're going to be into the pulp. Very nice guy, very well spoken. Just life got in the way. We're all seeing this every day. Patients come in and they have a big hole and it hasn't really hurt. It's been bothering them, like they know there's a problem there, but it just hasn't hurt. Well, we gave them all the treatment options. We could leave the tooth as it is, maybe medicate it, we could extract it, or we could try to save it. Now, where the decay was on the mesial part of the tooth, I thought there was enough tooth that we could get a ferrule down in that area. The buccal lingual was in pretty good shape. The distal was in great shape. It's just that mesial decay. I think the tooth had a previous MO restoration that I think was composite, and it just kind of broke apart, and then the bacteria started to get down into that area. Patient reports that he hasn't been to the dentist in about 15 years, so he's not going on a regular basis. So he's not the one most likely to return. So if I do the root canal, get him out of pain, he's probably not going to come back for the crown, or most likely not. And what the research has shown is if we do a perfect root canal procedure, but we don't seal the tooth up coronally, that root canal treatment is still likely to fail. If we have extensive decay and I remove a lot of tooth structure and I don't crown that tooth or restore it, there's a good chance the patient's going to bite on that and the tooth's going to crack. How many times have we had a patient that comes in, the tooth has split, and they'll tell you the story, oh yeah, my dentist many years ago did a root canal and I was supposed to come back for the crown, but they never did. So the protocol that we were going to follow, being that this patient is in pain, there's a large amount of decay there, and he doesn't go to the dentist on a regular basis, is a one-step procedure where we can do the root canal, get the patient out of pain, and feel pretty confident that if we do the root canal on Friday, he's not going to call us back on Saturday or Sunday. That's a big part. And then we're also going to do a single unit or single visit crown with our CEREC, so we can get this all done for the patient, make it convenient for him, but get everything done that he needs to have done, at least on this one tooth. So the protocol is to prep the crowns. What I do is I get in there, not trying to remove all the decay, because in that core area of the tooth, I may leave a little decay. I just need to be able to scan that and have the scanner see that there's a good tooth in that core, whether it be decay or not, right? That there's some structure there that it can get the impression of. So what I did is I just basically did the crown prep around that tooth, got all the marginal decay out. So again, on the mesial margin, there was a lot of decay, so I took that margin down below that area of decay. In the MO area where the old composite was that had broken apart, there was still some soft tooth there, but I left that there. I scanned the tooth. Once I scanned the tooth, my assistant begins to design the crown, and my other assistant and I, we go to do the root canal. Now, root canals have changed so much, and I just think it's really important for general dentists to do the root canals that you can, they have time for, that you want to do, that you feel like you have the skill set to do. This was a lower right second molar, and so a lot of GPs, we don't like to do second or third molars. We might stay second by or first by and anterior to that. But with this one, we went ahead and told the patient, okay, we'll go ahead and do it. He was 32. The nice thing about doing this root canal and doing the crown prep at the same time is I remove all the decay. I take the occlusal down and I just opened it up, and I could see the access points for the canal orifices very easily. So the objective is to design and mill the crown while we're doing the root canal procedure, and by the time we're done with the root canal procedure, we've got the restoration ready to cement. The core is going to be largely the cement that we're cementing the crown on with, because it's going to fill in the area where we've done our access to do our root canal, and it becomes very efficient for both us and for the patient. Now we know when we do a root canal, there's different parts. We've got to clean the tooth out. We need to shape the canals. The shaping allows us to get our irrigants down there to disinfect it. And as we shape, we're able to shape it so our gutta percha can get down there with our sealer, and we can seal this area up very well. And then ultimately a filling or the restoration that has to go on top of that. So we're going to really focus on the disinfection part. Why? Because we know that the initial treatment failure is often because there's persistent bacteria left behind in the canal. But if we can disinfect that canal, we can get a success rate that's very predictable. So many times we see canals that haven't been disinfected well, and the patients experience a lot of pain or residual apical radiolucencies. Saw a patient after this one that came in experiencing pain. We took a PA, tooth number 28, had a root canal done fairly recently in the last year, and there was still apical radiolucency down there that's causing that patient pain. So that didn't clear up. One of the things about doing root canals is when I was learning to do root canals 40 years ago, we did a lot of hand filing. So this was the box that I had when I was in dental school to store all my extra files. Now I know it doesn't look sterile. This whole box would get sterilized at the time, but now we use it more like a storage container in the office. But what I would do is we'd get our canal access orifice opened. We might take an 8 file, then a 10 file, and we were doing it all by hand. So we were using sodium hypochlorite as our irrigation solution, but doing a root canal, especially on a molar, might take us an hour and a half to 2 hours. And so we're filing, we're doing everything by hand. We didn't have the rotary or reciprocal systems that we have today. We had to feel that file. If it felt like it was getting weak, we'd have to toss it so it wouldn't break. We were dealing with different instrumentation. So it took a very long time. And all that time while we're doing our hand filing, we're irrigating with that sodium hypochlorite, sodium hypochlorite, sodium hypochlorite. We weren't using bioceramic sealers. So it was just basically sodium hypochlorite, rinse it out, dry it, get it bone dry, and then place our gutta percha with the sealer that we had at the time. Our irrigants had a lot of time to disinfect the canals. Today, it's a whole different ballgame, and that's why I enjoy doing root canals more today than I did 40 years ago. But let's go back to the goal of a root canal. The goal of the root canal is to get all that vital or necrotic tissue out of the canal system and the microorganisms and their byproducts, all the toxins that are in that canal or in the tubules that line that canal. Now, if we fail to do this, if we leave tissue behind or if we leave a lot of bacteria behind, we're not going to get a tooth that's able to heal. So it's going to be a non-healing situation. And what happens is you might have to retreat or refer that out, and we lose revenue. And the big part is we lose sleep, right? Because we don't want our patients to go through the root canal procedure and then experience any pain after that, because it's very uncomfortable. We just don't want that. So we need to be able to get in there. But the challenge has been that we take these files and we get it down into that main canal, but we know that off of that main canal, oftentimes there's a lot of little lateral canals that go off to the side that we can't get a file into. So as this illustrates, that file is going straight down kind of a main canal, but where we have all these lateral canals, we can't get that file to turn at a 90-degree angle and get into those lateral canals. We can't even see those lateral canals. So this is the file system that I was using on Friday, and they're the HiFlex EDM OGSF files with the enhanced irrigation. So this is a video just showing how fast this goes. So in about 2.5 minutes, this file system is able to clean out the canals. We're using irrigants in between the mechanized filing, and it goes very, very fast. So unlike what I was describing before, where if I was doing maybe a single tooth root canal, maybe it would take me a half hour, 45 minutes because I was doing everything by hand. Well, now watch this video. Basically, you're getting everything done in about 2 to 3 minutes. So this is a kind of an orifice opener type of file. We're not trying to get down into the curved area. We're just trying to open up our access opening to make it very easy for us to pass our files down. You can see that every time we use either a hand file or a mechanical file, we create debris. And so what we need to do is we need to use the irrigant to get that debris out of the canal. So there was the opener, then a little hand file to make sure we've got patency to get all the way down to the bottom. We don't want to be packing debris down there. We don't want to have anything that creates a ledge that doesn't allow us to get down to the bottom. So we're always confirming that we're getting down to the bottom. And these files, they are so flexible that they can follow those windy canals all the way down. So now we go to the next, and we're getting that more open. We're irrigating to flush out all the debris, and we take a little hand file to make sure that we have patency down there. So now we're going into the shaper file. So this is going down very gradual taper. We only take these file systems maybe to I don't know, you could go 25, 30, 35, 40 type of shape. We don't go out to the big 50s and 60s unless there's really a reason to do that. But as you see, this is a single canal. They're treating on a block, just going through the system, irrigating, checking for the patency with the hand file, and now a finisher. So the finisher is going to get the final shape established. You can see these files negotiate that curve very, very easily. This is on a cordless motor. The motor actually has an apex locator on it. So as I'm putting that file down into the canal, I can actually see where I am in relation to the apex and where I am to my working length. Well, that's just showing how once you get that shaped, now we put our gutta percha down there and it just goes all the way down. Very, very quick. Much different than 40 years ago when I was doing my root canals. And so that's what we have to figure out is if we're able to do our root canals so fast, what irrigants do we use to disinfect that? So again, an irrigant is something that you use just to wash out a cavity or wound. It's a medicated fluid. So that's our sodium hypochlorite. A disinfectant is an agent that destroys or inhibits the activity of microorganisms that could cause disease. So our sodium hypochlorite is our irrigant and our disinfectant. It will dissolve that tissue because, again, this is just a different file system and, again, a block. And that cloudy area in that middle part of that canal, that is the debris. There's no better way to dirty a canal up than to use a file because a file is going to pull all that bacteria tissue out. It's going to create the dentinal debris. And we need to flush that out. If you keep shoving it down into the apex, that root canal system may not heal up properly. So we need to irrigate, use lots of irrigation. I think that's one of the things I've come to realize now is that you have to use a lot of irrigant because if there's tissue in there and you put your sodium hypochlorite in there, the chemical reaction just creates a soap. So almost immediately it's neutralized. And so you need to flush that tissue out and then go back in there and re-irrigate. So Vista Apex has spent decades developing irrigants that are advanced irrigants that can keep up with the speed of our mechanized root canal systems. So the challenge is we find that main canal. How do we disinfect all those canals, lateral canals, and all the tubules that come off? The study that's often cited by Dr. Peters just shows that when we use our files, because they're stiff and they can't get into all those lateral areas and all the different shapes of the canal, that we leave about 35% of the canals uninstrumented. So if we do our best to use our files and yet we leave 35% of our canal uninstrumented, what's that going to do? Remember, we have to get that bacteria out. We have to get that tissue out. If I leave 35% of that bacteria and the tissue behind, what are the chances of us having success and for that healing to occur? And that patient we see on Friday is going to call us back on Saturday or Sunday. So it's going to ruin all of our weekends. So an irrigating solution should help to remove the debris. And you saw that in the videos. It's kind of like the washing to remove that debris. It decreases our instrument friction. So it can be like a lubricant, depending on the viscosity. facilitates the dentin removal, all that debris. The inorganic material, again the dentin, penetrates the canal peripheral tubules, dissolves the organic material like the pulp tissue, kills the bacteria. We need to get that bacteria killed, right? So the body can heal. But even if it's able to dissolve that pulpal tissue and kill the bacteria, we need it to be friendly to our patient. We don't want to irritate or damage the periapical tissue in that area. So it can't be too cytotoxic. Some of the common irrigants are sodium hypochlorite because that is the one that dissolves the organic debris. Now, what you see is there's other irrigants that come out, and they may be able to flush out the canal, but they can't dissolve the organic debris. They can't dissolve that pulpal tissue. They can't do a good job doing that. They might be able to disinfect that area, but if you leave that tissue behind because you can't dissolve it, then whatever irrigant that isn't going to be very effective. So we need to use sodium hypochlorite. EDTA is usually our second, now that we're using bioceramic sealers. What it does, it chelates and debrides the inorganic substances that are in the canals. So it kind of removes the smear layer. So if you're using a bioceramic sealer, think of this as a composite situation. If you're going to place a composite on a tooth, you'd want to etch it to open up the tubules to allow your adhesive and your composite to have the bond. Well, if we use a bioceramic sealer and we're using just sodium hypochlorite, it is helping to remove the debris, but all those tubules have the debris in it. What we do is we have to use the EDTA. The EDTA is like a phosphoric acid with our composite bonding. It's going to open up the tubules to allow our bioceramic sealer to get into all those little lateral areas and seal the tooth up better. So typically what we'll do is we'll use a sodium hypochlorite. That dissolves that pulp tissue out, removes the debris. Now, if we're going to use a bioceramic sealer, we flush out with EDTA. That opens up, by removing the smear layer, it opens up all those tubules. And then we go back in there one more time with sodium hypochlorite, because now the sodium hypochlorite can get into the tubules to kill the bacteria, to dissolve any more tissue. We will talk about using ultrasonic activation to help kind of wash those tubules out. Then we rinse that out, dry lightly. Some of the bioceramic sealers, you want to have just a little bit of moisture because that helps to set the bioceramic sealer. And then we place the bioceramic sealer in there with many times just one master gutta percha point. Whereas in the days when I was learning to do root canals 40 years ago, we didn't want to have a lot of sealer. We want to have a lot of gutta percha. Today what we can do is we can have a lot of sealer and just a little bit of gutta percha. The gutta percha helps to create a hydraulic force that pushes the sealer ahead of it and laterally, and then it gives us a pathway that if we have to retreat that root canal, we can retreat it. And then some clinicians will use chlorhexidine as an antibacterial solution just to really clean everything out. So let's go back to sodium hypochlorite. So sodium hypochlorite helps again to dissolve that necrotic tissue, the vital pulp tissue. It's an irrigating solution, help to get the debris out, and it's antibacterial. But Clorox goes back centuries. And the problem with Clorox, and I was taught to use Clorox, just to go down the store, buy the Clorox, dilute it, maybe 50-50 to get the concentration to 3 to 6%. But it doesn't necessarily work that way. By the time you get Clorox and you buy at the store, you never know. If you go down the store and you look at the Clorox bottle and it's all the way in the back of the shelf, it may have been that bottle that kept getting pushed to the back and all the new bottles got positioned in front of it. And that bottle, by the time you grab it, could be years old. Who knows? So what happens over time is it's exposed to time, heat, sunlight, is it degrades. And so let's say it left the Clorox factory at 6%, and 2 years later, because it's on the back of that shelf, you pick it up thinking, oh, somewhere around 6%, you dilute it. But because it's degraded, it was shipped during the summer, it got a lot of heat, got a lot of sunlight, and now you've got that prolonged time on the shelf. It could be at 2%, and now you dilute it 50-50, and now you're at 1%. I mean, you're basically back to water. Is that going to give you the effect that you need it to have? Is it going to dissolve the tissue? Probably not. Is it going to disinfect that pulp area? Probably not. Remember, Clorox was intended to brighten your clothes, maybe disinfect surfaces. That's about it. It really wasn't meant or wasn't designed especially for root canal procedures. So what I recommend is use a pharmacy-controlled sodium hypochlorite like Vista Apex cells to ensure consistency and safety. This sodium hypochlorite comes in a 3% and a 6%. You don't have to dilute it necessarily. If you just order a 3% bottle if you want 3% or a 6% bottle if you want the 6%. What are the advantages versus over-the-counter sodium hypochlorite, or Clorox sodium hypochlorite? Well, the Vista Apex sodium hypochlorite is pharmacy controlled, and we know the consistency and that it's safe. It's got a verified concentration with a shelf life. It's got a date. After that shelf life, you may want to dispose of your sodium hypochlorite, but use it up before it goes dated. It's quality controlled because it is designed, again, at a pharmacy or pharmaceutical level. It will dissolve the pulpal tissue because you know the concentration. Unlike that Clorox, we don't know the exact concentration. So it does. The Vista Apex sodium hypochlorite has a validated shelf life and expiration date, and it was intended for the clinical use of treating your patients that require a root canal, unlike Clorox. So I would recommend that you use Vista Apex sodium hypochlorite. So now we've got this debris. We're dissolving the pulpal tissue. We're disinfecting the pulp chamber. And what we're going to talk about is some advanced irrigants and some ways of using those advanced irrigants. So let me go back to the story we started with. Patient came in. We prepped the crown out. We scanned it. My assistant started to design and mill out the final restoration. My other assistant and I, we did the root canal procedure, got the root canal done, and placed the crown. Now, this was a patient that came in pain. When we gave him the anesthetic, he said, pain was gone. We were able to do the root canal. I used the file system we discussed. I used the irrigants we discussed. We got all cleaned out, cemented our crown on, and it was a win-win for everybody. So it was a situation where I hope we see the patient back, but if life gets in his way and we're not able to see him back, at least he's got the root canal and the crown. I don't have to worry about coronal leakage. I don't have to worry about him biting and fracturing the tooth. We've got it all covered and protected. So it was a good weekend for all of us. Anyway, hope to see you back at some more of our programs. If you like the content, please subscribe. We'd love to be able to tell you when we're putting out more. And we're going to get deeper and deeper into root canals and irrigation and so many other things. I saw a patient this weekend, came from about 6 hours away for some TMD work, and I want to share with you how we handled that. I've got patients this week, or doctors this week, that actually emailed me with dental implant questions. That was one of the programs we did previously, so I'd like to share more with that. And what we're going to do is, just as a community, we are going to grow, we're going to share ideas, and just have a good time. So thank you very much for joining us, and I look forward to seeing you during our next program. Take care.